Okay, did it start? Yes, there we are. All right, so welcome to the Houston Health Department Monkeypox Forum for Healthcare Providers. As always, we strive to add some value to your day. Today, we will be doing things just a little different than we normally do. We're going to take a break from all of the wonderful monkeypox info we have been giving you and have a spotlight on some Ebola information that we hope will also, be helpful to you. So we will start off with our, monkeypox data and a message from Dr. White, our local public health authority, and then we'll move on to some Ebola information about laboratory testing and the overall outbreak in Uganda. Okay. So once again, we keep this as an open forum format. This is your meeting, not mine. So please be mindful to keep yourself on mute if you're not speaking, just so it's, respectful to the presenters. All right. With all of that, welcome to the meeting, and I will pass it on to Dr. White and Dr. Purse if he's on for a local public health message.
So good afternoon, everybody, and thank you for being here. Dr. Purse may be jumping on, but a little late if he does. But on behalf of him and myself, thank you guys for joining us for this conversation. It's a very meaningful time, and we have been getting a lot of feedback and input from your organizations. So please keep that coming. As Roger mentioned at the very beginning, these should be meaningful conversations and resources for you as you all do the work on the ground of taking care of Houstonians. I know last time Dr. Purse did kind of start us off with sort of a larger landscape of how things are with COVID. And so as you all, many of you know, our positivity rate has still been low at about 5%. Wastewater slightly trended up from previously, it's at 83%, and the week before it had been in the 40s. But still, we're seeing that that's been just a slow, steady, moving, consistent, sort of low number with regards to the state of COVID in our community. And when we look at hospitalizations, when we looked at the TMC hospitalizations in particular, last week they've admitted 62 patients, and previously they had admitted 72 patients for the previous week. So slow and steady with regards to COVID. And then like Roger mentioned, we're going to transition from COVID and we'll go into the monkeypox, and then we have some great information with regards to Ebola. So again, thank you for being here, and we appreciate your support. With that, I will transition it to, was it Como? Roger, is she up next?
She is Dr. White, but I'm gonna run the slides.
Okay. Thanks, Kirsten.
All right, I was trying to turn my camera on. There we go. So let me go ahead and put these slides up for you guys. There we go. We'll go ahead and walk through this fairly quickly because there's not a lot of new information. Again, we always start off globally and move locally. So there are over 77,000 cases globally, which is an increase of about 2,000 to 3,000 from the last time we met. Again, the US continues to have the largest number of cases, followed by Spain, Brazil, France, and Germany. Globally, there have been 38 deaths, both in areas where monkeypox is endemic as well as non-endemic countries. And in the US, we now have 8 confirmed monkeypox deaths. If we look at our status in the United States, we are up to 28,000 deaths, and Texas continues to have the 4th highest case count. What we wanted to add for you guys today, just another different type of view, looking at the epi curve with the daily number of reported cases, as well as that 7-day average. And so you can really see that the number of cases that's being reported is dropping off as we've been moving through this outbreak. Switching over to looking at testing and positivity, cumulatively since the outbreak started, the positivity rate is currently at 27.7%. Again, we've been seeing, it hover around 21 to 25%. It did seem fairly stable for a while. Looks like there may be a slight increase in the weekly positivity rate as this continues to decrease, but we'll have to see if that continues or not. The population demographics remain stable. We're looking at cisgender males, generally in the young to middle-aged adult range. And the distribution of ethnicity, again, shifted over time, has remained fairly stable, does continue to disproportionately affect Black and African American persons. And so we do continue to work on equity. Switching over to Texas a little bit, we've got about 27,000 cases here. Again, most are between the ages of 18 and 49. Almost all of them are cisgender males, clustered in our largest metro regions. And Houston accounts for 25.3% of all cases in Texas. So I'm going to go ahead now and turn it over to Kamal to share the Houston specific information.
Great, thank you so much, Kirsten. Okay, so yes, for the city of Houston, using data as of October 28th, the 7-day centered positivity was 50%. However, we always do want you guys to take note that positivity rate can be unreliable with low testing. And so as you can see towards the end of that chart, we are seeing very, very low numbers of testing, which could contribute to that unreliability of this positivity rate. So, you know, just we say it, but take it with a grain of salt with the low testing rates. Next slide, please. And here you can see sort of like the epi curve for the city of Houston with the bars representing the number of new cases that we're seeing per day, and the pink line showing the cumulative case count. So again, you can see towards more recent dates, we are seeing fewer and fewer positive new cases. And that pink curve of cumulative cases is flattening out over the past few weeks. When looking at the demographic breakdowns of the positive monkeypox cases, you do see, you know, trends that are, as always, typically similar to the trends we're seeing by DSHS and CDC statewide and nationally. So most cases amongst that 20 to 39 age group, almost all cases in the male population, and seeing that demographic breakdown where we're seeing increasing proportions amongst the Black African American race group, and you know, race ethnicity has again been mirroring national and state trends pretty closely over the past you know, several months at this point. When looking at the cases spatially across the city of Houston, again, spatially has also remained pretty stable over the past several weeks. We see the most cases sort of in that downtown midtownish area with 77006 leading in case count, and you can kind of see it spreading a little further east as well with the majority of cases. But this just gives kind of a spatial overview of where we're seeing cases across the city of Houston. Switching gears to vaccinations, just under data as of Monday, October 31st, just under 8,000 individuals have received at least one dose of the monkeypox vaccine. Of those, 75% of individuals, of those who are eligible, have completed their series, so received that second dose. Those who are eligible, meaning who have are at least 28 days past their first dose. There are about just under 2,300 individuals who are considered overdue, so past their due date for their second dose, meaning more than 35 days past their first dose. When looking at the demographic breakdowns of the vaccinated population, again, you know, most of the vaccinations are amongst the male population, and the majority are in that 19 to 39 age group where we are seeing the most cases as well. When it comes to the racial and ethnic breakdowns of vaccinations, we do see a little bit of disparities. So Black African American populations account for about 38% of the monkeypox cases, but we're only seeing them account for about 16% of vaccinations. So we are working towards, bridging that gap. Similarly, Hispanic and Latino populations account for 33% of cases, but only 28% of vaccinations. So there is a little bit of a, again, disparity, but we are, working continuously to reach out to the populations that need. And to wrap it up, seeing the overlap between monkeypox positive individuals and HIV positive individuals, there are about 39% of monkeypox cases who are also HIV positive. And just over 21% of these monkeypox and HIV positive individuals are not being virally suppressed currently. And so they might be a harder to reach population because they may not be seeing their provider regularly. I believe that is it for the data we currently have to share.
Thanks for that update. I always appreciate that. It's good to see that we're making progress on this epidemic. But, we're not out of the woods yet, right? I would like to reiterate to everyone, the STOMP project for TPOXX is still a really good option. If you have a patient who you're thinking about prescribing TPOXX, I highly recommend getting them involved in that project. That'll be our ticket to get TPOXX out of EAIND and into pharmacies. So the more information they have, the better. I went and posted that link in chat. I just wanted to plug that real quick. So next up, we're going to shift our focus over to Ebola. Not that we are in the middle of an epidemic or anything here, but I think that information is our best weapon in any of these outbreaks. So we wanted to be proactive and give you some more information. So I will pass this on to Meilon Bilby, who is our clinical manager here for Houston Health Department. Meilon.
Okay, let me share my screen. Can you see my screen?
Not yet. Now it's there.
Thank you. I'm going to talk about Ebola testing at the Houston Health Department lab. It's not moving. I do not know why my slide is not moving. Okay, sorry about that. The contents I'm going to cover include Ebola testing method, BioFire warrior panel, testing availability in US, testing requirements, specimen collection, specimen packaging and shipping, testing turnaround time, and some additional information. Start with testing method. The current Ebola outbreak in Uganda is caused by Sudan Ebola virus. The previous CDC PCR method for detection of Zaire Ebola virus cannot detect Sudan Ebola virus. The BioFire full-array warrior panel currently is the only FDA-approved testing method for detection of Ebola virus, containing 5 species, including Zaire Ebola virus and Sudan Ebola virus. The testing method cannot distinguish among different Ebola species. For example, it cannot tell you it is a Zaire Ebola virus or Sudan Ebola virus. A little bit more information on the BioFire warrior panel. The warrior panel was designed to detect 5 agents: Bacillus anthracis, Yersinia pestis, Francisella tularensis, Coxiella, Ebola virus, and Marburg virus. It is a PCR-based testing method. CDC only provides verification material for 3 agents on the panel, which are Bacillus anthracis, Ebola virus, and Marburg virus. Our lab has performed verification and will test specimens for these 3 agents. Some other labs might choose to test for Ebola virus and Marburg virus only. Results are for the presumptive identification. The confirmatory testing should be performed at the CDC or Department of Defense. It is a low throughput testing. We can only test 1 specimen at a time. In US, 29 LI lab and some Ebola treatment center have received BioFire instrument and the verification panel. As of this week, 26 LI lab across the nation have implemented this test, and we are one of them. In Texas, State Lab in Austin, Dallas LI Lab, and Houston LI Lab have received BioFire instrument. Austin and Houston Lab have implemented this test. Dallas is expected to go live by next Friday. The 3 Texas LI Lab also cover the testing need from our neighboring states, Oklahoma, Louisiana, New Mexico, and Arkansas. UTMB Ebola Treatment Center Biocontainment Unit is expected to implement this test sometime around the end of this year for specimens from patients who receive treatment there. It is unclear if they will test specimens from other submitters. This is how BioFire instrument looks like and the screen. Testing approval is required for Ebola virus testing. If your facility has a suspected Ebola case, always call your local or state health department first. Your local or state health department epidemiologist will work with CDC subject matter expert to determine if testing is warranted. No specimen will be tested by our lab unless approved by CDC. If testing is approved, you can proceed with specimen collection. For specimen collection, collect 2 tubes of whole blood using plastic collection tube. EDTA purple top collection tubes are preferred. 1 tube is for our lab and the other tube is for CDC. Do not use glass container. Label each tube with patient's name, date of birth, test request which is Ebola, and the date of collection. For each tube, collect at least 4 ml whole blood for an adult and 1 ml for a child. Do not separate and remove serum or plasma from the primary collection tube. Store both specimens at 2 to 8 degrees before shipping. Fill out our lab and the CDC test request form per requirement. You can refer to the guidelines we sent out yesterday. If the patient's symptoms have been present for less than 3 days, a second set of samples should be collected 72 hours after onset of symptoms to rule out Ebola virus. 1 specimen will be shipped to our lab and the other specimen will be shipped to CDC for confirmation testing. Each specimen should be packaged and shipped as Category A infectious substance by certified personnel at the submitting facility per applicable regulation, mainly Department of Transportation and IATA. Each specimen should be packaged following the triple packaging system, which consists of a primary container wrapped with absorbent material, a watertight and leak-proof secondary container, and an outer shipping package. Do not package suspected Ebola specimens as Category B infectious substance as you would for regular diagnostic specimens. It is not safe. One specimen should be shipped to our lab cold at 2 to 8 degrees, and the other specimen should be shipped to CDC frozen at less than -20 degrees per each entity's guidance. Again, you can refer to the guidelines we sent out yesterday. Details on testing arrangement will be discussed during consultation call among the submitting entity, local and state health department, and CDC. The picture on the left shows the triple packaging system. The whole ship can be purchased from company like SafePack. So the primary tube is the specimen tube you have together with the absorbent material. You can put it into the watertight, leak-proof secondary container. Then you put a cap on, lock it, and put it into the ice chest together with the outer packaging. For the specimen to be sent to our lab, you will put sufficient cold packs surrounding the secondary container to maintain the temperature 2 to 8 degrees during transit. For the specimen to be sent to CDC, you will put sufficient swab ice surrounding the secondary container to maintain the temperature at less than 20 degrees during transit. So you can see this is a very safe packaging system. Even if the specimen tube breaks or leaks, all the liquid will be absorbed by the absorbent material and contained in a watertight and leak-proof secondary container. Never ever package suspected Ebola specimen as Category B infectious substance as you would for regular diagnostic specimen, like in the picture on the right. Our turnaround time for a result is 6 to 8 hours after received at our laboratory. If everything goes smoothly, sometimes PCR run failed for controls or specimens, and we need to repeat the test, then it will take longer. I also would like to mention some additional information. Most rule-out Ebola cases will likely have other disease, especially if the patient has no high-risk exposure. In many instances, cases with similar symptoms have been related to malaria, which is endemic and a leading cause of death in areas where Ebola outbreaks are. Patients suspected of having malaria infection should be evaluated immediately per CDC guidance. The bottom line is patient care and routine diagnostic testing should not be delayed. I have heard that clinical lab in some facility refuse to perform diagnostic testing for patients who have travel history but do not meet persons under investigation for Ebola testing. Keep in mind that proper care and diagnostic testing should be provided is the law, and it can be done safely through risk assessment and proper biosafety practices. And here is the contact information if you have questions on Ebola testing. That concludes my presentation. Back to you, Roger.
Thank you, Meilon. I appreciate that. That's always great info. Yeah, thanks for putting that number up. And Yes, so anybody has any questions about, having a PUM or needing testing, the first step is always to contact your local health department, and we'll help you get sorted out. All right. So our next presenter is Kirsten Short again, and she will be giving us an overview of the current outbreak of Ebola Sudan in Uganda, and the tracking methods and things that are already in place currently in the state of Texas and locally. All right, take it away, Kirsten.
Hey, good morning. Again, my camera seems to be tricky, but it looks like it's working. Let me go ahead and share my screen as well. It's good to be with you all again. And there we go. All right, y'all should be able to see that now. So thanks. As Roger mentioned, I'm Kirsten Short. I'm the Chief of Epidemiology for the Houston Health Department, if y'all haven't met me before. So we just want to give a little update on Ebola virus disease. So I want to thank my partner, Melan, over at the lab for going into that detail about testing. So over here, we're going to really run through EVD basics, or Ebola virus disease basics. The outbreak history a little bit, the status of the current outbreak, the risk of EVD currently, and then finally, some considerations that you and your facility may want to start thinking about if you haven't already. So starting at the beginning, Ebola virus disease, or EVD, is a serious illness in humans with a high mortality rate. So it's caused by infection with one of 4 viruses within the Ebola virus genus, which is within the filovirus family. This particular outbreak is caused by the species Sudan virus, which will be a little bit important as we continue to go through here. EVD is considered a zoonotic condition, and that's anticipated that bats are the most likely reservoir. It's spread through contact with body fluids of a person who is sick or died of EVD. And when we say contact with body fluids, we really do mean all body fluids. It's been detected in blood, feces, vomit, urine, tears, saliva, sweat, semen, vaginal fluids, breast milk, and amniotic fluids. I did take this slide from the CDC COCA call that they had for clinicians earlier this month. So let's talk a little bit about EVD progression. All right, so as we talked about, infection happens after exposure to a person or their body fluids of a person who is sick or has died of EVD. The incubation period is generally about 2 to 21 days, and it usually goes from about 4 to 17 days. During this incubation period, the person's going to be asymptomatic and they cannot transmit the virus to others. At symptom onset, the symptomology is really divided into 2 phases, what we call a dry phase and a wet phase. So that dry phase occurs first, generally from about day 0 to day 4, and it's going to be symptoms like fatigue, fever, headache, joint and muscle pain, sore throat. So these are pretty nonspecific symptoms. And then around day 4 of illness, the patient usually progresses to the wet phase, where you're going to see additional symptoms, including diarrhea, nausea, vomiting, bleeding in some cases, although not in all, eye redness, and so forth. And then as symptoms progress, as they go from the dry phase through the wet phase, the viral load increases and that patient does become much more contagious. And then in fatal cases, death usually occurs around day 7 to 10 of illness. And at the time of death is really when the patient is most contagious. So when we talk about treatment and prevention, remember we're talking about, this is an EVD, Ebola virus disease caused by the Sudan virus species. So there is no FDA licensed treatment. There is something called MPP 134, which is an experimental antibody cocktail that shows some promise. But really supportive care, and particularly supportive care initiated early, is key to increasing the chances of survival. If we remember back to 2014 and the patient that died up in Dallas, the staff at that facility were assisting him to the commode, upwards of 10 times an hour. So there really is, quite a bit of volume loss, and that vomiting, diarrhea, IV fluid support, and so on becomes really important. So switching over to prevention, there is no FDA licensed vaccine for Sudan virus. There is an Ebola vaccine out there. You may have heard of it, but it provides protection against the Zaire strain, which is the strain that caused the 2014 outbreak. It does not appear to provide cross protection against Sudan. There are several vaccine candidates in the works, and so there have been discussions with the WHO and the Ugandan Ministry of Health looking at possible field trials. So let's switch over to testing. I don't want to talk too much about this because Milan just went through that so well. But again, it's a panel that was developed by the DoD, initially only available at 8 laboratories, and CDC and APHL have been working really diligently to scale up testing availability. And just like in the early days of COVID, the early days of monkeypox, Zika, back in the 2014 Ebola outbreak, testing requires consultation and approval with public health. And in this case, we're talking about really talking with your local, state, and ultimately CDC. So let's switch gears a little bit and talk briefly about the history of EBD outbreaks in Africa. So EBD is caused by an infection with one of 4 viruses within the Ebola virus genus of the filovirus family. So the one that we're probably most common with is Ebola virus, which is the species Zaire Ebola virus. It's the most common. It's in red on this map. And we can note that the size of the outbreak correlates with the size of the circle. It's generally felt to have the highest fatality rate, and it caused the largest outbreak back in 2014-2016. There are a couple others, Bundibugyo, forgive me if I mispronounced that, and Thai forest. Thai forest is in green, Bundibugyo is in yellow. Thai forest has only caused 1 case that we are aware of ever, and that person did survive. And then finally, what we want to focus on is Sudan virus, which is the species Sudan Ebola virus. It's in blue on this map. You can see these outbreaks have been occurring in Sudan and Uganda across the years, and it's caused several outbreaks. There we go. So a little bit more about the history. There have been 33 outbreaks caused by Ebola virus, which is that Zaire species. So most of our knowledge about EBD comes from outbreaks that are caused by this Zaire virus, which includes, again, the West African Ebola epidemic, which is the largest ever. They had 28,000 cases and over 12,000 deaths across Guinea, Liberia, and Sierra Leone. And they did have spillover events into other nations. So if you remember, if you were back in healthcare, particularly at that time, or public health, Nigeria had a small outbreak when they had some cases in their capital of 20 cases. Mali also had another small outbreak of 8. United States, we had 4 cases. Remember, we had the patient up in Dallas, as well as some of his caregivers were affected. And then additional single case spillovers in Italy, Spain, Senegal, and the United Kingdom. And I will say for Italy, Spain, and the UK, those were all in healthcare workers who had been over providing assistance with the outbreak. They were asymptomatic when they returned to their home country and were monitoring. And so they were able to really be well contained. And then in Senegal, it was an ill traveler, but also identified early and well contained with no secondary cases. Before 2022, there have been 7 outbreaks due to Sudan virus. 5 of those had less than 20 cases each. The largest was back in 2000 with 425 cases, and that second largest was back in actually 1976 when Ebola was first identified with 284 cases. So let's switch again and talk about this current outbreak, which is happening in Uganda. So the first confirmed case was identified by PCR on September 19th. It was a 25-year-old male who was living in the Mubende district of central Uganda. And the next day, the Ugandan Ministry of Health declared an EBD outbreak. So further identification identified a cluster of unexplained deaths in the community in the previous months. This chart over here is from the Ugandan EBD outbreak SITREP situation report 40 and is current as of October 31st. The blue has confirmed cases. The maroon are probable cases ordered by date of onset of symptoms. September 19th is really about here in the middle of this report here. Switching to where we are today, mostly, as the most recent SITREP that's been put out. So as of October 31st, which is 42 days into the outbreak, Uganda has 130 confirmed cases with 21 probable cases, 43 confirmed deaths with 21 probable deaths, which is a case fatality rate of 33% among the confirmed cases currently. There are 7 districts that have confirmed cases, including the capital district. And these are outlined in red over here on this chart. Mubende district, which is sort of right here in the middle of these districts, where the outbreak was first identified, accounts for 55% of all of the confirmed cases. This graphic is from CDC, readily available on their website, and it's being updated when districts are added to the affected list. So let's talk about the risk of EBD spread. So initially, WHO assessed the risk of spread at low for both the global and regional levels. On November 2nd of this week, they updated the risk assessment to high at the regional level, meaning there's a potential for spread across countries in Africa, but continued the assessment to be low at the global levels. The nations surrounding Uganda have been monitoring the situation closely as this since September and are initiating their own actions. So the risk of importation to the United States continues to be assessed at low. There are a couple reasons for this. We average across the nation about 140 to 150 passengers per day who are coming into the US and have been previously in Uganda. There are also no direct flights between Uganda and the US, and Uganda very rapidly initiated exit screening of air passengers exiting their country. But on the cautious side, the United States initiated passenger routing and screening at 5 US airports on October 10th. Again, if you remember back to 2014 in Ebola, there was a similar strategy that was put in place then. So passengers are routed to one of these 5 airports, and about 90% of passengers generally pass through these airports already. They go through a health screening, which involves some questions, confirmation of some information, and more recently, CDC has begun providing disposable phones for people who do not have a US-based telephone number. That information is collected by what we call DGMQ, the Division of Global Migration and Quarantine. It's sent out to the travelers' destination states, wherever their final destination is, and then from there, those states either handle that directly if they have a centralized public health system, or like we have in Texas, decentralized, they divvy that information up to the local health departments. Local health departments go ahead and reach out to those travelers, reconduct a risk assessment with them, and then continue some sort of follow-up with them depending on where they fall within that risk assessment. Texas has received some travelers. As of the update they provided on October 31st, all are in the low or no identifiable risk category. The no identifiable risk category means someone was just in Uganda in the previous 21 days, but not in an affected district and not participating in any high-risk activities. Someone who is in the low risk category would be in Uganda and in an affected district in the previous 21 days, but again, no additional risk factors or activities. So let's talk about considerations. As Roger mentioned, we just want to bring this to your awareness. The risk of importation to the US is low, but we always want folks to be prepared. So as a facility, what should I be doing? The first thing is really dusting off my Ebola plans from 2014, right? And thinking through a scenario of a patient who comes through your door and looking at considerations around screening, differential diagnosis, isolation, and notification. All right, so let's start with screening. We want to collect a travel history for ill patients with a clinical picture that's suggestive of an infectious etiology. And we're talking about Ebola right now, but we went through travel histories with Zika, with the onset of COVID, with the previous Ebola outbreaks. Really, many of us in public health really think that there's a case for travel history, both domestic and international, to be a routine part of a medical visit. We've got malaria that is endemic. Here in the US, we have Lyme disease, and those are just a couple examples. But getting back to Ebola, did they travel to an area with an active EBD outbreak in the past 21 days? Were they in close contact with someone who's confirmed or suspected to have EBD? What activities did they do? Did they do any potentially high-risk activities, participate in a funeral, care for someone who was sick or died? Did they travel with someone who's now ill? Let's think about differential diagnosis, right? So you want to include EBD in differential diagnosis in ill travelers recently arrived from Uganda. There are no spillover cases at this point, and so travelers to any other part of Africa or to any other part of the world do not need to be tested or considered testing for EBD. But you also need to remember, I think as Melan mentioned, malaria is the most common cause of undifferentiated fever after travel to sub-Saharan Africa, and it shares signs and symptoms with EBD. Malaria can progress rapidly, so you should not delay malaria testing due to EBD concerns. And let's also remember, to Dr. White's comments at the top of the call, we're in cold and flu season. You know, common things are common, so you also need to consider viral respiratory illness when symptoms are compatible. We switch over to isolation. So if you do end up having a patient with exposure history and signs and symptoms consistent with EBD, go ahead and isolate that patient in a single room with a private bathroom and the door closed. And if there's not a private bathroom available in that single room, go ahead and put a commode in that room that can have a cover on it. You want to follow CDC guidance for infection control and PPE use. And you want to limit your healthcare worker interactions and keep a log of everybody who goes in and out of that room. Finally, let's go ahead and talk about notification. As Roger mentioned, notification is important. If you have a patient with a relevant exposure history or travel history and symptoms that are compatible with EBD, you want to notify your facility's infection control lead, and then you want to reach out and contact your local, regional, or state health department. Because you need to remember, testing is going to require public health approval. For many of you, Houston Health Department will be your health department. Our 24-hour number is 832-393-5080. If you don't know who to call, you can reach out to the Department of State Health Services Regional Health Office, 713-737-3000, and they can certainly help direct you to the appropriate department. The other thing before we leave is I do want to offer up a number of online resources that can be useful. So first of all, the World Health Organization puts out disease outbreak news about different topics. So they have a section that have put out a couple of DONs about the Ebola outbreak in Uganda. Secondarily, the WHO Regional Office for Africa with the Ugandan Health Ministry is putting out EBD sit reps. So we've got a link to those there. I also want to mention earlier in the month, CDC had a COCA call, which is Clinician Outreach and Communication Activity, for an update on the 2022 Ebola outbreak in Uganda. While their numbers may not be correct anymore, because it was earlier in the month, there's still a lot of good information in that call. The website has the slides for the call, as well as a recording of the call if you weren't able to join. I also want to highlight that on that page, there's a resources section. And that section contains links to several useful pages within CDC, including guidance on doing malaria testing when EBD is also in the differential, patient screening, PPE use, and many other pages. Here's one of those that we mentioned, CDC guidance on screening patients for Ebola virus disease. And then finally, I also want to bring up NETEC, or the National Emerging Special Pathogens Training and Education Center. NETEC, there's a group of agencies that were funded to support a center around emerging special pathogens, particularly in healthcare facilities. They have trainings, they have resources, and they're available for consult as facilities develop response plans. And within that, they certainly have an Ebola resource library, which has a lot of useful information. So with that, I just want to thank you for your attention and for your partnership as we go through this and all of the other diseases and outbreaks that we addressed throughout the years. Thank you.
Hey, thank you. I appreciate that, Kirsten. So that is the conclusion of our presentations today. We've got about 12 minutes left, and we want to dedicate that time to questions and discussion. So if you have any insights or questions, please, this is your forum, so you can turn on your camera and ask a question, raise your hand, however you want to do that. We're here for you. Not seeing any questions so far. Any hands up? Dr. White or Melan or Kirsten, do you have any other anything that came up that you wanted to address in more detail? Or
I do not, unless people have questions.
absolutely. Okay. Well, I do hope that everyone found the information we provide today valuable. The takeaways, I think, are that we, at least as a regional health department, are happy to be an information resource for you, and we want to help out. So if you do have any questions, please reach out to us. And the recording for this presentation will be placed on our website in the Monkeypox page. So look for that in the next couple of days. If you want to share that with your colleagues. Okay, well, I don't want to keep you guys away from your lunch if you're waiting for you. So thank you all for attending. And yeah, and as Chris said, encourage everybody to get a flu vaccine. It's definitely going around. So you guys have a great weekend, and go Astros.
Yeah, and we'll see you
Thank
soon.
you so much.
Thanks, everybody.
Thanks, everybody.
Thank you.
Thank you.